Hello. Primary total hip arthroplasty is being called the surgery of the century because, as we know, it improves people's life and movement. But all the information we have is always related to regular cases. When we talk about cementless porous cup, we find out that there is a huge amount of them. These are the primary cups that were developed as many surgeons have developed their own. This is the first generation. As you see, most of them are not longer in use. And it's very interesting because the most important thing is that all were looking for the direct union of bone and implant, and Albertson found that in retrieve cases that you need 4 to 12 weeks to have the initial bone interface with new bone. The complex indications for primary total hip are abnormal bony anatomy, severe arthritic conditions, severe hip injury, and others. And the most important thing is that you have anatomical issues and structural issues. So we can deal with this, but when you are discussing about osteoarthritis, it's not the same. The revision rate for total hip arthroplasty in primary, as you see, when you see the records, is always the same in all the records. When you talk about osteoarthritis, it's lower. When you talk about specific patients like dysplasia, rheumatoid patients, and post-fracture patients, you have an increased number, and the number is always increased during the first 4 to 5 years. So what we know is that in this kind of patients, we have to find out which is the solution of the new bone implant integration. Here you have different evaluations and which are the reasons for a revision. And as this is always related to inflammatory arthritis, osteonecrosis, dysplasia, and post-traumatics. As you see, with hip dysplasia rheumatoid, during the first years, generally you arrive to a 5% of failure during the first 5 years. So we have to improve this. When you see osteonecrosis, the aseptic looseness rate is increased and almost duplicate the instability complications, and post-traumatic is about 5.4%. So it's always around the same number, 5 to 8%. So cementless hip porous coats, caps change during different generations. I show you the first generations, then came different generations, and now we arrive to the highly porous coated 3D printed, and we have different results. And they are really promising because in this paper, in example, when you see when you have only arthritis is 60% of the cases, but when you go to the other 40%, the failure rate is what makes the difference. When you analyze this paper, you have no major complications, no radiolucencies, lines, or osteolysis, but when you go to what it fails is the cap and the stems, always in this kind of complicated cases. When you go to the dysplasia, in this paper, 68 patients, 100% of survival rate, and these are a group of young patients, 61. The more demanding patients are more prone to fail, so we are achieving a new way of solve this kind of complex patients. The most important thing here is that the bone graft is incorporated, and as you see here, there is a huge change of the pattern after 1 week, a year, and after 9 years. So the transfer of the load around the cap is improving. When you talk about Lecpertes-Calvé, in example, you have 61 patients, really young, 42 years, 100% of survival rate, but still the follow-up is short, it's 5.6 years, and no implant migrations. With rheumatoid arthritis, 45 patients, 55 years. This is a mix of different covers for the cups. The cups were titanium and tantalum. It is supposed that it's similar, but it's different the way that the materials perform, but you have no radiolucencies. So it seems that this kind of cups will perform really good. In our cases, we use directly the tracer. We have 37 patients. We followed them up to now at 3.5 years. We have no cap migrations. The only thing is that we found this, These are the most low transfer that are really good, but the problem is that the radiolucencies we found are because the cap is flat in the polar zone. So sometimes we need to do something with that, that's a little bit of a reaming. This is a technical issue that we are trying to figure out in time what is happening. With pigmented synovitis, it's similar. We have 8.5 years of follow-up with titanium highly porous cap and no cap migrations. In acetabular fractures, it's very interesting because there's a new trend in the trauma guys that they are trying to use in some kind of fractures with not a huge displacement, directly using peripheral support and use caps with highly scratching index. And this is very interesting because in these cases they have no radiolucency lines and no cap revisions. They use part of their head, the head that were removed directly as bone graft, and the bone graft is performing really good in contact with the new cap. This is similar. Here you see another one, but this is a paper we published when we find that our trauma team used to pass us when they have failure, and this patient has more than 2 years of complaining about the hip never working, and we find out when we do the approach that the head was really scratched, and this is the screw. In many cases, we are required to do a partial removal, but basically we try to remove only what is in the middle of our way. Otherwise, we keep with what we have. And we use the head as a bone graft, and after implanted the cap, the patient works well. Here is a conversion of another catastrophic cases. If you see, probably there was a bad indication of the initial nail and a bad indication of the second conversion, and the rescue, I think that is good. But when we collect the cases, we find out that every moment that you make a mistake, you increase your risk. And when you are increasing your risk, you are damaging all the structures around. In osteonecrosis, we are working now, we are dealing with this. We are doing a comparative study. These are our preliminary results. It's a prospective match control study. We have only 4.7 years of follow-up. We find out that the functional clinical are improving as good with no differences, but in the last review we see that there are still a remaining pain in the thigh. After 2 years, most of the patients complaining of the pain in the thigh are prone to disappear, but when we look, the caps all were integrated and we have no revisions up to now. In other cases, I show some cases that are from here. In Pachet patients, the one that my previous speaker showed, the warfarin was really amazing. When they show me this case, I see that the potential of these caps are really amazing, and the conversion of the arthrodesis. And this is something that we are always published at. The ImageG software is a free software. I recommend you to use it if you are having some kind of you are having not clear if the prosthesis is performing well and is well also integrated. You can draw a window somewhere here as marking a part of the range of interest, and with different scales of gray and black, the computer will tell you if the bone is going to the implant or is going, is leaving the implant. So you can define all the different Moore signs. So this will help you in the daily practice. So the 3D printed highly porous titanium caps, in example the tracer, are really good for this kind of primary total hips arthroplasty. The primary stability is the most important thing. The scratching that you get when you start is very important. In our cases, the contact initially, when we have dysplasia or epiphysiolysis, we try to achieve at least half of the contact of the peripheria, and this is enough. Sometimes we apply some support, but when we go and see what is happening, sometimes we put some bone graft, and the peripheral bone graft that is not supporting the load, it will disappear. So, but when you look with the ImageG what is happening, we are looking at the usually 4 or 5 of the Moore signs are completely done with the cap. So the cap is really well integrated. The issue now for me in the future will be what is going to happen if you have to remove these kind of caps. And the other issue is what are we going to do with the poly, because when the poly will fail, what are we going to do with it? Because in the previous generations of cap, the locking mechanism weren't all changed in time. So we started to deal with cement a cap inside the cap or something like that. I hope this will perform as good as we wish. And we have only 5 to 8 years of follow-up, and this is really promising. Thank you.